And I'll record it to this computer, and then it will be made available. It sometimes takes us a day or so to put it on the web, but it'll be available for everybody. So welcome, everyone. I'm very excited to present some of our preliminary data. And I'm guessing that probably some of you are participants in this study. So just wanted to thank you up front for allowing us to be able to do this work and gain more information about glioma. So today's goal is to specifically talk about individuals with lower grade and/or IDH positive glioma. And you probably all know that these topics, it's a bit of a moving target. The name, the diagnosis has changed a little bit over time. And one of the things that we wanted to do, because it really has not been studied very much, is to look at germline cancer genes. And we'll remind everybody what that means. Because part of the question is there are a lot of cancer genes out there, and I'm sure you've heard of some of them, BRCA1 and 2. But glioma generally has not been considered a part of them. And you'll also notice, and you can kind of think about your medical experience, in many instances, the patient is not asked in a neurosurgery or a neuro-oncology clinic about their own family history of cancer. They're sometimes asked, I think, about a family history of a brain tumor or a glioma, but not typically asked about not typically asked about other cancers in the family, which it turns out from what we're finding is actually an important aspect of knowing whether the glioma patient may carry a gene that's of interest. So we'll talk a little bit more about that. So these are the questions that we're going to talk about today, and we don't have the answer to every question, but we're also interested in getting a sense from you as either patient or caregiver, researcher, healthcare provided, your thoughts on these issues. So you may or may not know, but inherited cancer syndromes do account for a pretty good proportion of cancer risk. And within general medical oncology, they are an important focus. Most cancers, so for example, breast cancer, ovarian cancer, have very standardized consensus testing guidelines. For example, if you are diagnosed with breast cancer, it's very typical that you would be asked about family members with breast cancer. At what age were they affected? What sort of cancer did they have in addition to breast, ovarian, etc.? And there's a very set number of rules about when a patient with cancer should undergo additional testing, i.e. whether they might carry a specific cancer gene. And the reason that's important is these genes are typically associated with a higher risk of cancer, and could be breast, ovarian, colon. And so different screening guidelines might be suggested not only to the person tested, but to blood relatives of the person tested. So not much of this work has really been done in glioma. And I see one or two researchers on today that actually have led the charge on this. But the studies that have worked on this so far have tended to be the higher grade glioma or glioblastoma. So we know that there are a number of very rare inherited syndromes, and glioma is a part of those syndromes. But more generally, when we look at cancer genes, really it's not known how prevalent it is. There's a few studies out there, but you can see here the range of what's reported. So this number represents among individuals with glioma, what proportion carried a cancer gene. So it ranges from 3 to 15. So obviously not a very stable estimate, but it's interesting to think that as many as 15% of glioma patients might carry a cancer gene, and that information might be important to both the participant, but also their blood relatives. It is notable, and this highlights why it's so important, to have your family history of cancer taken in the clinic is many patients who did show up with the cancer gene, as might be expected, had either a second cancer themselves or had a family history with cancer. And even the definition of family history of cancer is a little bit hard to define, right? Pretty much everybody has at least one family member or perhaps two who had a diagnosis of cancer. That's pretty common. So where is the line to say this is a significant family history or this is sort of a standard family history? When you're doing this sort of testing, it's like any test within medicine. You have to decide what's the risk and what's the benefit. And in this instance, it's not only the risk or benefit to the person getting the testing, but it also affects their blood relatives. So you have to consider if you have a finding, then in many instances, that means that relatives may have a 50-50 chance of also having this gene. Do they want to know about it? What would they do or not do? If you're working with, your children, they may be still quite young. Do you want them to know this? Do you not want them to know this? If you want them to know it, how old should they be? So would there be screening? And that typically is what does happen frequently, is that there is screening. So you might get a mammogram, for example, more frequently, or they might say, not a mammogram, but we're going to get an MRI for the breast. You might have a colonoscopy. So there's all sorts of things that might happen, which you can choose to do or not do, once you know that you or a family member has this diagnosis. The other issue, and this is not yet well known, is would treatment for your glioma be any different if we knew something about one of these cancer genes? We'll talk a little bit more about that. That is true for other types of diagnoses. We don't really know the answer yet for glioma, although there is some evidence that people that have these genes may respond differently to things like chemotherapy and or radiation. So important to think about. So I think most of you know about the International Low Grade Glioma Registry, but of course I have to use this as an opportunity to advertise a bit. So this is our worldwide registry to try and study essentially lower grade IDH positive glioma. We have a wide range of things that we do. We look for genetic factors, environmental factors. You may or may not have seen some of our work looking at glioma in firefighters. And also looking to see, because as I'm sure many of you have experienced, it's really not clear what the exact best treatment is for lower grade glioma. And as we now have this new class of treatment, which I'm betting that at least some of you are on, called IDH inhibitors, it is not clear, should I take the IDH inhibitor? If I do, when should I start it? Should I do it with other treatments? So there's lots of unanswered questions, and our registry is part of an effort to gain information on that. So just a guideline who can join the registry. It is a registry of adults, so 21 years and older. We do require a pathology report. It's grade 2 or 3 glioma, but now we've moved more broadly to what's called IDH positive glioma, regardless of grade. And if you do have any questions or interested in joining, you can go to glioma@yale.edu or to our website. I do see some of our wonderful NIH staff on our webinar today, so thank you for joining us, and thank you to NIH for its support of our study. So within the low-grade glioma registry, we have a study called Optimum. And this is an effort funded by the National Institutes of Health to study the molecular evolution of glioma, basically to try and figure out what's the best treatment, at what time should we give it, and when we do give these treatments, what happens to the tumor? Are we making things better? Are we making things worse? Are we helping patients or not? And how does that help us to decide what to do next? One of the aspects of this study is to study germline, and we're also looking at the tumor, but inherited changes that might be important both for risk of glioma, but also in trying to figure out what the best treatment is. So I know many of you know the difference between germline and somatic, but I just thought I would go over it again and help clarify too. I know over the years we've asked for a number of different samples and you may have signed different consents, so thought it might be helpful just to review. So germline genes are those that are inherited from your biologic mother and father. We can examine a number of different tissue types. It's typically blood and saliva. And some of you may have given a blood sample and then we came back and for additional testing asked you for a saliva sample. And we'll talk a little bit about why that is so. This is the information we can use to inform both the patient or the person getting the test and their blood relatives about risk of cancer. And in some instances, it does change treatment of the participant. The term somatic refers to the non-inherited or the genes that are in the tumor. And so for many of you, we've asked permission to collect your tumors, and we're looking at genes in those samples as well, but that will not be the focus of today's talk. The information we gain there tells us about the patient prognosis and also how they may respond to treatment, but it doesn't tell us anything about family members. Research versus clinical level. So I know many of you have done both of these, but just to be a little bit clear and to help sort out some of the emails you may have received from us. So research level, typically in our study, we have asked you for a blood sample. We've either drawn blood in a laboratory or a clinical setting, or we've asked you to fill out one of these blood spots where essentially we prick your finger, you tap your finger on this card, and it's very easy for us. I mean, it's really sort of amazing. We can take even just one of those dots and do genetic testing. That testing has been done at Yale and it is research level, meaning that it is not quite as high level as something that we would use in a hospital or clinical setting. So we've also then, as the years have gone on, been able to partner with a company called Ambry Genetics, and they perform what's called clinical level testing. Clinical level testing means that it can be used in a medical setting and may help direct your care or defining what prognosis might be. In our study, this has involved a saliva sample. So I know some of you first gave a blood sample and then we came back to you and said, we now can offer this clinical level testing. Would you be interested? And if so, it requires a saliva sample. There's a lot of different forms, but basically it's a very glamorous process where you receive a plastic tube, you spit into it, and then we send it to the company and they do the testing. So what is this testing? It's a very specific testing. And as I mentioned, it's our partnership with Ambry Genetics. We're able through our NIH grant to offer this during the time of the grant. So it's a panel of 77 cancer genes. So what does that mean? These are genes that have been associated with risk of cancer. We ask for the saliva sample, so we would send that out to you. You collect the saliva, send it back, all the postage is free. And then the test results, and it's been pretty quick. We've gotten test results generally within a couple of weeks. They're made available to the participant. Obviously, as the research team, we have access to them as well. And if you wish, we will also send it to whatever healthcare provider you indicate. If you don't want to send it, you don't have to. We do encourage people to send it to their healthcare provider. So participants that have a finding that's important, i.e., looks like one of the cancer genes, is positive or is found in your sample are then provided with, and this is all done via, Zoom televideo. You don't have to go anywhere. You receive a 1 hour genetic counseling session, and that's just to basically let you know what the results mean, what you may or may not want to do. And then also there's free testing for this finding in your blood relatives, and that's available for 90 days after the participant testing. So if you have a finding as positive and you're interested in having your children tested, your siblings tested, that is all able to be done. But note, it is a 90-day window. So you would have to, go to your family and tell them about this. And that is offered for free to them. The report looks something like this. So this was an example. And I will say that any of the results we share here, we have obtained written consent from the participant to present these. So we make sure that you get it, your healthcare provider gets it, and then you and your healthcare provider would decide what, if any, further testing or medical action would occur. We have also, in addition to people who had a positive test on Ambry, which is clinical level, we have sent a letter and an email to those for whom our research level testings were positive to encourage you to move next to the Ambry testing. So who is eligible for the testing? It is pretty similar to who is eligible overall, but there are 1 or 2 restrictions, and this is basically related to government restrictions, not specific to our study. So who's eligible for the Ambry testing? You still have to be 21 years of age or older. Governmental restrictions only allow us to offer it to individuals currently who live in the United States or Canada. You have to have a confirmed low or lower grade glioma. Typically, the diagnosis is called astrocytoma or oligodendroglioma, or any IDH positive glioma, regardless of what grade is. If you have any question about whether you're eligible, just email us. We're happy to talk with you or review your pathology report, and then we can decide if you're eligible or not. So what would you have to do? We do need to confirm that you are a real person, and that you truly have this diagnosis. So you would have to give your pathology report to us at glioma@yale.edu. We can review it and say yes or no, you're eligible. And then we do have you sign a research consent because we have to have permission to forward your contact information to Ambry. And then you're automatically enrolled in the International Low Grade Glioma Registry and can participate or not as you wish in our additional studies. If you're already on our email list, you know that we send out different opportunities. You can ignore or not ignore, or just, get our newsletter, just be up to date with different opportunities that are out there or information that might be of interest to you. So what have we found so far? So far, we have germline findings on 128 individuals, and we have another big batch coming. 15 of those individuals did have positive findings. So a relatively high rate, almost 12% of our participants had a positive finding. And this is just in the 77 cancer genes that we're looking for. So these are the names of the cancer genes. I'm not expecting you to really recognize the names of these. If you are a cancer researcher or a physician, many of these are fairly commonly found and known. TP53 is a part of the Li-Fraumeni syndrome, but most of these are in the category of something called a DNA repair gene. We'll talk about that in a minute and why that can be important. In these individuals, which we're now starting to look at, we're trying to see, well, what were the discerning factors? How could we have figured out ahead of time who was likely to have a cancer gene and who was not? And it's not perfect. Having a family history of cancer was certainly an important factor. And 3 of our participants have been generous enough to allow me to share their family history with you. There wasn't any difference in age by finding, and that's sort of interesting. It may just be 128 seems like a lot of people, but in the land of statistics, that is still sort of a small sample. The reason we look at age is in many cancers, people that develop a cancer diagnosis at an early age are more likely to be a genetic carrier, right? They tend to have more family members affected. Everyone's affected at an earlier age. They may have multiple cancers. We did not see that here, but it may just be that it's a small sample size. The one thing that's interesting, and I do think there's some bias in this, is the majority of individuals that had the positive findings were biological women or female. Now, this may simply be who decided to pursue the testing. So it may not be truth that the women are more likely affected, but it was quite striking that almost everyone that was positive was a woman. So we still have to figure that out. So what do these genes do? Most of these genes are called DNA repair genes. And exactly as the name sounds like, the genes help to repair damage to DNA in cells in the body. And so, we're out there damaging our DNA every day, right? Sun exposure, smoking, all sorts of different things. Your body does try to repair the damage, but it doesn't always work, right? The damage doesn't always get fixed. And some people have different copies of these repair genes, so they don't repair things quite as well as other individuals do. These genes can also affect, right? Because think about when you're getting chemotherapy, when you're getting radiation, the idea is that there is some DNA damage being done to the cancer genes. If you have a germline finding, that might affect how that treatment is working on you. And so that's something we want to start to think about. In some inherited syndromes, for example, Li-Fraumeni other, sometimes if you're getting radiation, the radiation oncologist may reduce the dose of the radiation that you get. Now, I've asked around my neuro-oncology friends, and I see a few of them on today, that in general, I don't think is really used in neuro-oncology in present. So it will be interesting to sort of see if that is important to do. We do have some information that certain germline findings can be associated with differences in outcome for glioma patients. Most of the data is from higher grade, but there is already some evidence, particularly with the use of Temodar, that your outcome may vary based on not only what the tumor is showing, but what your germline information is showing. So I wanted to show you a few examples of some of the more interesting family history, which is also called a pedigree. And we did obtain permission to present the following slides. I really want to thank those individuals and everyone who's participated. We obviously cannot do this without you. And the fact that you would also let us share information about you, I think is so helpful to others when they're kind of processing information and deciding what they want to do or not do. So thank you so much. So just a little, I've cut off certain pieces, but this structure or diagram is what's called a pedigree. It's essentially a picture of individuals' family history. Circles are generally biologic females. Squares are usually the males. A line through the individual means that they have passed away. And so typically you color in a square or a circle if that individual has a diagnosis of cancer. And then typically below you list the cancer. So this was a family, an individual, and that's this circle here. They are what's called the sort of index case, or the person that you start the family from. They have a glioma, and they have two family members that have a glioma. So obviously in a clinical setting, that would make us suspicious that there is something happening. But what's interesting here is they also have two family members with lung cancer. And this is why it's so important to get all the details, because cancer can be associated with a gene, but cancer can also be associated with environmental exposures. And the family member here reported that both these individuals did have a strong history of smoking and potential exposure based upon their job. So you probably have some things in a family that might be genetic, some that might be environmental, and of course, there's always the possibility that the two combine. Now, what's interesting here is the gene that was found actually is associated with an increased risk of prostate cancer, not glioma, not lung. But that information may be helpful to the male family members. Maybe we could say to them, you're at an increased risk of prostate cancer, which, men are already at a high risk anyway. You might discuss with your doctor to say, I'd like increased screening, or maybe I'm going to start screening a little bit earlier. So that's a kind of a real world example of how this information might be helpful. So here's a second family, and this family, the individual had an oligodendroglioma, had another family member with glioma, but also had some other cancers. All right. And so this is an example, and this was in a DNA repair gene. This is the name of the gene here. And so these individuals, there is a set screening guideline for individuals that carry this gene. But what's important to see here is it's driven not just by saying, do you have a family history of a brain tumor of glioma, but the import of including all the other cancers in a family. Don't just stop at glioma, yes, no, brain tumor, yes, no. Think about other cancers that might be in the family as well. And here's our third and last example. So this is a family that I think you can see, the little purple circle is the individual that asked for the testing, oligodendroglioma. And those of you that are involved in cancer genetics and screening know when you see this family, which in many of the instances we're showing, no one had really taken a cancer family history for these people. So they didn't even know that that was an important thing to do. So that's one of our points today, is know your cancer family history and make sure you relay that information to your physician. So the individual had an oligo. Now, nobody else in the family has a glioma, right? So if your doctor or nurse is saying, do you have a family history of glioma? You say no, you go on, nothing happens. But they have a very significant history of colon, breast, other cancers. And it turns out this is a gene that's associated with BRCA2, which many of you know has an increased risk of breast, ovarian, colon, and other cancers. So just the import here, make sure you get that full family history. Very important. So what's the benefit of testing, and what's the downside of testing? We've mentioned a few of them, but I'm just kind of pulling them together here. It may suggest additional medical screening that could be of benefit to patient and blood relatives. Now, the one thing that we have seen with glioma patients, especially if you're actively in treatment, you're potentially not feeling like having additional medical screening. It's already tiring. You've had a lot to do already, and that is completely up to you whether you want to pursue anything. Blood relatives may benefit, especially in particular if you have children, right? If you carry a gene they have a 50% chance potentially of carrying it. You may want to know, or your siblings. There is some suggestion that treatment could vary, but that really is not something that we're doing at present. It's more something to be investigated in the future. And obviously, some of it is just altruistic, helping us as researchers to learn more about what is the true prevalence, what do these genes do, how may they affect treatment, and how can we identify things we might do better. And so one of the things we're interested in when we're looking at all these treatments, including this new class, IDH inhibitor and others, is there any difference in response based on not only, what your tumor looks like, whether it has a IDH 1 or 2 mutation, but whether or not you have anything in the germline that's important. So all of these are things that we're trying to answer. We did want to put a call out. We don't know who's on today or not on today, but there are individuals in our study who have positive research level findings, but they have not yet pursued the clinical Ambry testing. We have contacted everybody, but we actually have not heard back from anybody. So we wanted to encourage individuals who have a positive research level finding. So that, it's sort of suggestive, but it's not the ultimate test. The testing is free during the time of our grant, which is probably at least another year and a half. So please, if you're interested, contact us to pursue the clinical level testing. And with that in mind, we do always want to keep the patient efforts and concerns in mind. We do understand that this may be adding one more piece of information onto your plate that you feel concerned about or that you feel anxious about. And we are seeing that in our study. And we'll tell you that, we're part of a research consortium called the Patient Engagement Cancer Genomic Consortium. And that is true across all the groups, regardless of what the patient's diagnosis is. We are seeing a low uptake of this testing. So I'll just give you some of the numbers here. So right now in our optimum sub-study, there are 320 people that would be eligible. That's how many participants we have so far. Now, we do have some people that are deceased, so obviously they're not going to be reachable. Of those, only 55 have pursued the testing, meaning they signed the consent. And then of those 55, only 26 so far have sent back the saliva kit. Now, of those, 4 are positive, and then only one person has elected to pursue the cascade testing, which, remember, that's the testing, the free testing of your relatives for the variant that was found in the participant. So this obviously is showing us that although people are interested, they do have some concerns about gathering this information. And, we're happy to hear from you, your thoughts, to see if we can learn more about, what might be more helpful to you. So our conclusions, and then we'll go to the question and answer, and I'll stop the recording so the question and answer doesn't have to be recorded. That glioma does appear to be part of these cancer family syndromes. We think that there should be more testing, but obviously it doesn't make sense to test everybody. So we're trying to start and work on guidelines so that among all glioma patients, who might be a subset, that we would go forward to test, even if only to offer benefit to the patient's family members. Obviously, we don't want to test everyone. We don't want to over-test. To highlight the import here of reporting your personal and family history of all cancers, not just glioma. Because most of the participants in our study are relatively young, we did not have many people have a second cancer. We really only had one person, and that was someone who had a known Li-Fraumeni result. There's also some thought that we might gather information from the participants' tumor results. So most patients, when they have a glioma surgery, do have a panel of genes that is tested. Now, each hospital may do testing on different genes, but there are kind of core genes that are looked at most big institutions or tumor hospitals. And that can also help to guide if you see certain findings in the tumor, that might help to say, oh, you should probably do the germline testing. And we did actually have one participant who had already had outside testing, and they had it because there was a finding in their tumor that was suggestive. They got the germline testing and did indeed have the finding in the germline. You do have to think carefully, especially if you have children or minors involved, the benefit and risk, both to the participant as family members. Would treatment for the patient be altered? For example, would you lower radiation? That's an unanswered question, but it does happen in other cancers, so something to think about in the future. And we just wanted to highlight, we do have remaining funds to test persons through about a year and a half. Once our grant ends, we won't have the funds to offer this. So if you are thinking you might be interested, please let us know. And then we have to get our little ad in. We are on social media. We're learning more about social media every day, but we have an email site. We have a website if you want to just see what it's all about. We do put the webinars there, and we have a newsletter there. So if you just kind of want to know about what's happening and not participate, you can also be on our email list. These are our handles. Annie, who I think Annie Heffernan, who many of you have met, has been doing a great job on our social media efforts, and we are finding some help with that. We do want to thank everyone who has helped to support our study: the National Cancer Institute, American Brain Tumor Association, National Brain Tumor Society, Low Glio, many other institutions. You can see these are some of the institutions that work with us. So some of you may have enrolled through these sites. And obviously we thank the participants. Sometimes family members get back to us, sometimes physicians help us out. So we did want to thank everybody. We really do appreciate your efforts. So I will stop the share. And here's my little head here, and let me stop the recording.